receptor, it's a G protein coupled receptor that's overexpressed in a variety of cancers, not just prostate cancer. And we were very fortunate over the past decade or so that prostate-specific membrane antigen, PSMA, was introduced first as research, then clinically. It revolutionized the way we identify disease and we treat disease for many of these patients' prostate cancer. But biology has multiple redundant processes, so identifying one biological target in cancer is not enough, or not enough for all patients. Even under the assumption that 90% of patients overexpress PSMA, it doesn't mean that 90% of all lesions in all patients overexpress PSMA. So we need access to other biological targets to be able to get a full understanding or a better understanding of what's present in a patient as far as prostate cancer. And because GRPRs are overexpressed anywhere from 60 to 100%, depending on the stage of disease, they offer an alternative in cases where PSMA is not overexpressed or not highly overexpressed. So this study was initially designed in 2013, before the introduction of PSMA. PSMA 11, 11 stands for the year 2011 when it was discovered and introduced. So at that time, we had to compare it with standard of care, which was CT or MRI and bone scans. The PET in PET-MR at that time, the PET-MR scanner that we used, was the most advanced, the most sensitive PET. So we wanted to design a study where we take the most sensitive PET to enhance the chances of finding disease, and the anatomical modality, in this case, MRI, in a single exam to be convenient for the patient. These days, there are also advanced PET coupled with CT. We also have digital PET-CT scanners these days, extended field of view PET-CT. So our results can translate and can be used with PET-CT as well, not just with PET-MR. But at that time, the PET in PET-MR was the most sensitive PET available clinically. So we wanted to take advantage of that. And as far as eligibility, we wanted patients who have proof of biochemical recurrence by ASTRO Phoenix criteria post-radiation therapy and by AUA criteria post-radical prostatectomy. And we wanted to see if adding PET to the standard of care anatomical imaging will lead to additional lesions being identified. So for eligibility, patients were required to have biochemical recurrence as well as a negative CT or MRI and a negative bone scan. So for that time, the eligibility were pretty tight. So we designed the study powered to show superiority of the combined PET and MR over MR alone. And overall, MR was about 30% positive, and PET plus MR was about 70% positive. So we want to be honest to truth here. We did not biopsy every lesion, so that's why we called it positivity rates. Some findings were proven by biopsy, but in many cases they were not. It was a composite standard that, you know, depending on follow-up imaging, follow-up PSA, etc. But we've shown that we exceeded our expectation here with 70% positivity rate in patients with negative conventional imaging. So we are very happy about that. Since the study was studied and funded, of course, PSMA became available in the US first as a research tool, then FDA approved. So about 60 patients of this cohort also had PSMA PET within a few weeks of each other, and we reported those results separately. About 2/3 of patients have similar findings, with the other third having different findings on PSMA and GRPR PET. And I think that both cohorts are important because, of course, if one scan is positive, the other one is negative, it's very straightforward. You go with the one that's positive. But if there's overlap where some lesions better seen on one, some lesions better seen on other, it may have implications for the treatment option, because just like lutetium PSMA, you can have lutetium GRPR. And so even if you see the same lesions, you can, for example, in the future, design a study where you alternate cycles so that you reduce toxicity from each agent while maintaining efficacy. Coming back purely to diagnostic purposes, I think that a patient should be evaluated with both to see where he starts as far as the biology of their prostate cancer, and then follow them up with whatever shows the most lesions. And if in the future the scan is negative despite rising PSA or other biomarkers, then you can switch to the other, hoping that you'll be able to find the disease. 'As expected, because we inject such tiny mass of radiopharmaceutical and low activities, we did not have any SAEs or major things to report. So in this cohort of 100 patients, there were nothing to report as far as safety. 68Ga-RM2 is one of a class of agents. There are others out there that have similar biodistribution and hopefully similar results. So we need to get one of these approved by the FDA in the next few years, hopefully less than a decade. And then we need, just like with PSMA, we need to explore it at various stages of disease. We have published small pilot phases using RM2 and PSMA to guide biopsy in men with high-risk prostate cancer and negative or equivocal MRI of the prostate. We used it to guide local treatment and publish that in high-intensity focused ultrasound, HIFU. We use it prior to prostatectomy in high risk and at biochemical recurrence. So we want to cover the full spectrum. And I think that there's a lot of work left to be done to find what is the clear position of this class of radiopharmaceuticals as related to PSMA, which is now the gold standard, I would say.